Pediatrics. Pediatrics, everybody gets freaked out about pediatrics. I used to get freaked out about pediatrics, but pediatrics is really simple. Pediatrics is sick, not sick. And if they're sick, there's only a few things you really got to do, okay? And let's talk about, the majority of this lecture is going to be focused on what to do, how to determine if they're sick or not sick. That's the first half of this lecture. So. All right, opening reminder, they're just little adults. That's all they are. They're just little adults. No matter what anybody tells you, they're just freaking little adults. I'm telling you, man. All right. When you're dealing with kids, keep in mind, at a minimum, you have 2 patients. You are never just treating the kid. And what's the 2 things that you've got to do in your job? What are the 2 things you got to do? If you remember from the very first day you were here, the 2 things that I told you got to do. You've got to make sure it's not something bad, okay? And the definition of bad is that it results in some kind of disability or death. You got to make sure it's not something bad, because if they die or they have some bad outcome, it reflects poorly on you. And you have to make them feel better, right? With pediatrics, it's not just the kid that you have to make feel better. It's the parent that you have to make feel better, all right? And that may be just, you know, just telling them it's going to be okay. Most of the time that I spend with kids, it's trying to reassure the parents that I'm not a complete imbecile and that everything is going to be okay. Because that's what they look like. All right. A couple of kid-specific problems is that bumbles bounce, right? Their fontanelles are not closed, so they can tolerate more ICP, or they don't get rib fractures or any other thing. They don't break like adults do. They bend. But as a consequence, they suffer more severe injuries from similar impacts, from similar traumatic events. So if you can hit a kid in the chest with a baseball bat and not break a rib, but destroy the spleen and liver, okay? The intubating them is much harder because they're more anterior and it's not really smaller. I mean, yes, obviously it's smaller, but it's smaller at a different point. In adults, it's smaller right at the vocal cords. In kids, it's smaller just beyond the vocal cords. So you'll get the tube past the vocal cords and not be able to kind of get it past there. And then their head makes them look like a bowling ball on a popsicle stick, you know? So they flex more, and you will have, as a consequence, you can have cervical spine injuries without cervical vertebra fractures. It's called SCWORA, spinal cord injury without radiographic abnormality. And then the bone fractures. Does anybody know what that classification in the bottom right is? The Salter-Harris classification, 1, 2, 3, 4, 5. Salter-Harris 1, 2. Does anybody remember how to remember those? So it's Salter, S-A-L-T-R. Slip, which is right through the growth plate. Slip above, so the fracture goes above or proximal to the growth plate. Slip above, lower, below the growth plate. Through, which is both above and below. And ram, which is a crush of the growth plate. Slip above, lower, through, ram. That's Salter 1 through 5. S-A-L-T-R. So, you know, you can sound like a really cool guy when you get your little speed gun x-ray and you get on the phone with whoever you're calling and you say, hey, I've got a 4-year-old with a Salter 3 of the distal radius. And he'll be like, yeah, okay, what do you bother me for? Just put it in a splint. Okay. All right. They get there are some differences between adults and kids. You know, obviously that first slide was the first part. This is the other part. Decreased glycogen stores, unless you're an American kid, in which case you've got plenty of glycogen stores or at least a bottle or bag of Skittles in your freaking pocket, right? Which means when they do get sick, they'll get hypoglycemic, and then you're really in trouble. Different drug metabolisms, that's true. They do go through drugs differently. They'll metabolize drugs at different speeds than adults. But in my experience, that has not shown to be a big issue. Hypothermia is a big issue. Kids have a little bit more surface area and they'll get cold faster. Now, that kid won't, but a baby does, okay? Babies will get cold fast. Has anybody ever run a trauma patient in yet? Run a trauma patient in from EMS? Nobody? Really? Ooh, that sucks. Yeah. Yeah. Did you stick around long enough for them to get their temperature when they got here?
We did have one yesterday. She was 93, I think.
Yeah.
Yeah, they get cold.
Yeah, they get freaking cold. Now, and you know that trauma patient wasn't left out. You know, they're usually covered up in the back of an ambulance that's heated. You know, it's not like we left them out on the ground in the parking lot while they got shot or something. And yet they're still 93, and we know that contributes to coagulopathy, right? Kids get colder faster than the adults. So a kid that's in a trauma or a kid that's sick that you leave out will be 93, and then all of a sudden you end up with a lot of problems with glucose stores, especially if they get hypothermic. They cannot increase their stroke volume, okay? Their stroke volume they're usually maxed out. So when a kid will try to, you know, if they drop their peripheral vascular resistance, let's say a kid is septic, and they need, normally it's like, let's just make up a number, 5 liters per minute of cardiac output they need. It's actually more like 2 for that kid. So they need 2, but all of a sudden they're sick and they're gonna need like 3 or 4. Well, they're already maxed out on their stroke volume, so they compensate by increasing their rate to increase that cardiac output. Well, at some point they can't keep up, right? So let's say all of a sudden they need 4 liters per minute and their heart can't keep up because they're already going 180 beats per minute. And now you run into a filling problem, right? And all of a sudden their cardiac output is insufficient to meet their metabolic demands, and then bam, now you've got a hypotensive floppy kid. That's what happens. That's why kids get floppy and super sick. And what you do is you just give them a little bit of fluid. That's the thing, is that the hard part is identifying sick versus not sick, but once you identify that they're sick, it's usually pretty easy to manage it. It's sugar, fluids, maybe a little epi if you're in a lot of trouble. Super easy to dehydrate, decrease renal concentration. All right, here's your thing. Now, you don't have to remember the triad as much as you just remember these are the 3 things that you should be looking for. One is the appearance. You just look at them, you know, you're like, that looks like a sick kid. Work of breathing, whether they're having difficulty breathing, grunting, tachypnea, wheezing, the work of breathing. It's not necessarily breathing sounds, it's whether they look like they just got done with a 5K. And then circulation of the skin, whether they're mottled, cyanotic, pale, etc. All right, appearance. This is like this. Appearance is like a kid in the ER should be kind of pissed off. Maybe kind of either pissed off that they're there or, you know, playing with their, you know, transformer, whatever. You know, they should be behaving appropriate for the situation. A sick kid is one that really kind of, you get the impression that they don't care, that they're sick, and that they're just kind of allowing their environment to wash over them. That's a dead giveaway that you're dealing with a sick kid. They should be alert, grabbing at things, looking around, and then they should be able to be consoled. If they're crying, the mom and dad should be able to make them better. You should be able to make them smile, you know, make a glove balloon. If you make a glove balloon and toss it at them, a normal kid will like catch the balloon and be, you know, they could be like 4 weeks old and they'll be like, you know, not 4 weeks, but. A kid that just lets the balloon hit him in the head, that's a sick kid. And then focusing, glazed over eyes, not focusing, strong, spontaneous cry. You know, they should be talking. You know, the kid that we had was sick, just laying there. I mean, this kid was sitting on mom's lap with his arms down, just kind of looking at you. He'd track you, but he wouldn't get up. He wouldn't do anything to make you, you know, he wouldn't reach for you. He wouldn't resist if you were trying to listen to him. He was kind of mad that we were doing that, but he wasn't reacting appropriately. They should look like a kid. They should look like a kid, and kids are usually pretty pissed off. So that kid is in respiratory distress. Work of breathing. Work of breathing, you have to sit there and listen to him. Okay, you have to sit there and listen to him. A normal kid, the best way to describe it is that is in quotes, and this, I learned this, 20 years ago, moves air effortlessly. They should not have to work at breathing. So number one, look at them. If they should be appropriate to the environment. They should be engaged with the environment. Second thing is work of breathing. They should not look like they are working to breathe. The one that we saw was, he was grunting. He was grunting, he had a little bit of wheeze, but he was primarily you were looking at him, you were like, man, you are just struggling to stay, to breathe. The other parts is, I think that grunting is probably the biggest, to me, grunting is the biggest warning that that you're dealing with a sick kid. Wheezing, most kids wheeze. The hot potato voice in the later time, they got to be conversant, 2, 4 years old, before they talk like this, That's kind of epiglottitis, parapharyngeal stuff, nobody was with me. We had an asthma kid recently that he would not move. He was sitting sideways on the cot. This is last week. He's sitting sideways on the cot, holding onto the rail of the ER bed like it was a roller coaster. And he was leaning like this. He had his butt back and his head up, and he was doing everything he could just to breathe, okay? If you look at him, you can tell, but you gotta stop. You gotta look. I mean, the person that we saw, the kid that we saw, had been sitting in the waiting room for a while. You gotta sit and look at them. You gotta look at their appearance. You gotta look at their work of breathing. The retractions, a lot of kids have retractions. I mean, they just do. Normal kids have retractions. The nasal flaring, that's a giveaway. Grunting and nasal flaring are kind of, there's wheezing, and then there's, this retractions, and that's what everybody looks at. But for you, the real keys are nasal flaring and grunting. Those are right up at the top. And then color. There's 2 colors, well, 3 colors that you should be worried about. Number 1 is no color. Okay? If they have no color, you're in trouble. If they're like waxy looking, you're in trouble. That's a kid that's bled out or abused or something. Something else is going on with that kid. The second one is cyanosis. That should get your attention. Now, keep in mind that the kid might be cold. So beware of just having a cold kid. The third one, and the one that everybody kind of blows off, is mottling. Now mottling, it looks like a pizza. If you look at that kid and that kid's skin looks like a pizza with cheese and tomato sauce, okay, you'll have little white spots and it'll be reticulated, okay? That's mottling. Typically, if you're seeing mottling, it could be that they're just peripherally constricted, but if you're in a warm room, they shouldn't be mottled. If they're mottled, they'll probably also be cool. The kid that we saw was mottled and cool with grunting and inappropriate reactivity. I mean, he had all 3, and yet his urgent care people just kind of blew him off. All right, what's the difference between peripheral and central cyanosis? Can anybody characterize that?
So peripheral cyanosis is only the extremities.
Yeah.
Cyanotic and central is.
What kind of patient do you typically have peripheral cyanosis with? Newborns. You guys have all seen that by now, right? You guys have all been catching kids. They all have this acral cyanosis, right? They all have purple fingers. You shouldn't see that in a 2-year-old. Central cyanosis, they're not blue. They're not blue, but what you'll see is their lips look brown. Their lips look brown, or
Dusky. I like the
dusky. Yeah. They're not blue. And especially in African Americans or dark-skinned people, it just looks darker. It just looks grayer than normal. But it doesn't look blue, especially in kids. If you see a gray, dusky-looking kid, chances are you just need to breathe them. Okay? That kid has insufficient respiratory reserve. They're not breathing effectively. I hate capillary refill. I think it's one of the biggest bunches of crap. All you gotta do is get that kid cold and their cap refill goes to crap. You know, it's the other part. It's modeling, cyanosis, and pallor, which are the most important, physical exam findings. I never check cap refill. Look at this. This is a perfect picture of acral cyanosis or peripheral cyanosis. And that one on the top was modeling. Did you see that? Okay, yeah. All right. If all three is absent, you're good. Okay? So this is a pissed off kid, a pissed off pink kid that is screaming his head off. You're good. A pissed off pink kid is okay. They're screaming. Okay. They're probably in pain. Look for what's causing the pain. Hair tourniquets, corneal abrasions, but you're not in trouble. Okay? If you have a kid in respiratory distress, they have increased work of breathing. Respiratory failure means that they look sick and they have an increased work of breathing. But if you've got an inappropriate reactivity with the environment and signs of peripheral constriction, you might be dealing with like a pneumonia or some other signs of shock. And then if you're in the bottom, you're in, when the kid we saw had mottled cool skin, grunting, and was completely oblivious to the environment that he was in. That kid was much sicker than anybody had previously identified. So, though, if you walk away with remembering nothing else, just remember those three things, because at some point soon, you're going to walk into a room or somebody's going to bring you a kid and you're going to be like, what do I do now? If you can just remember these three things, write them down, tattoo them on the back of your freaking trigger finger, whatever, this is a good place to start. Okay. Reactivity, the primary survey, tape systems. I hate tape systems, okay? Especially Broslow. Now, I tell you that Broslow is an excellent tool to estimate weight, but the drug information on Broslow is for codes or something. The drug information on the Broslow tape is wildly inappropriate. To the point where I think that the Broslow tape is very good at estimating weight, but so is age. Do you guys know the age thing, right? The hand-heavy age thing? All prime numbers, right? 1, 3, 5, 7, 9. And then 10, 15, 1, 3, 5, 7, 9. 10, 15, 20, 25, 30. That's their weight. Okay? Don't worry so much. You probably will get a question about GCS, pediatric GCS. So do know that. I will tell you that I don't, and I never use it. Okay? I just never use pediatric. It's more important for you to be able to describe the patient than it is for you to be able to knock out, because I guarantee you the person that you're talking to doesn't know the pediatric Glasgow Coma Scale. Guarantee you. It's more important to be able to tell AVPU. In kids especially, everybody remembers AVPU, so that's great. Pediatric GCS, yeah. All right. Secondary survey. So your primary survey is that three-sided triangle, right? Three-sided skin, work of breathing, and what's the third one?
Circulation.
Circulation. After you're done with that, that's like walking in. Your primary survey, you should be able to do your primary survey from about 10 feet away. After that, you sit down, you start interacting with the kid, and you start asking the parents all these other questions, which starts with, what do you have to have before you do anything else? You have to have a chief complaint. It's what you use to develop every subsequent question. You have to develop, like, what problems are you having that you've come to the emergency department or the clinic for today? You got to start there. Fever, cough, abdominal pain, back pain, butt pain, arm pain, whatever, fall but you got to start somewhere. After that, then you do your OPQRST, and then you get your past medical history. It's the same thing. Then go through your physical exam. Now, how many people have ever been in a room with me when I did a physical exam? I don't think anybody has. That just sucks. Your physical exam should be just like JMPI, okay? Do the same thing every time. Make it a routine, something that you do the same way every time so you don't miss anything. I know that everybody starts with their head and works down, but I'm telling you, if you walk into some Southwest Asian female and get right up in her face and start looking in her eyes, her husband is gonna poke you in the back of the head, right? So I usually start as far away as I can, start asking them questions, and then as the conversation progresses, and I'm pretty sure they're not gonna freaking try to stab me, then I will always put my right hand on their right ankle, and I will get their posterior tibial pulse. And that tells me if they have peripheral edema, it tells me the temperature of their skin, it tells me what their heart rate is, and then I put my hand on their calf and squeeze their calf to see if they have calf tenderness, put my hand on the other calf. See, my physical exam is like JMPI. I put my right hand on their right ankle and give it a squeeze, and then I move proximally until by the time they get done telling me, you know, Aunt Martha's cherry pie made them sick 4 days ago, my physical exam is already kind of over because I've moved my way up, and now I'm listening to their lungs as they're telling me, you know, that they swallowed something or they have something up their butt, whatever. All right, so here's how it can go wrong. The first half of the discussion, we talked about how to identify a sick kid. And now we're going to start talking about how kids are sick. And that is the Misfits. This is your differential diagnosis for a sick kid. That's what this is, okay? The Misfits. And that goes trauma, heart disease, hypovolemia, endocrine. What's an endocrine problem in a kid? New onset diabetes, okay? Metabolic, inborn errors of metabolism, seizures, formula problems, intestinal disasters. Big one, especially in that first 2 to 3 weeks of a kid's life. You get big problems with toxins and sepsis. There's a little bit of overlap there, but that's a decent, good initial list. All right. For trauma, what is the mechanism of injury? Did they fall? Did they get hit by a car? Were they shot? You know, did they get blowed up? But you have to kind of, trauma is different than any other chief complaint. Trauma is a chief complaint, which kind of messes it up. Because after trauma, then you like just start highlighting areas of their body that is hurt. Never disregard the medical component of trauma. You know, quite often, especially here, you have an old guy that passes out and wrecks his car. And he passed out because he's having an MI. So never forget the medical component of trauma. Don't just start going through, you know, broke right arm, broke right leg, Foley, bilateral IOs. You got it. All right, priorities of effort remain the same. Remember differences in anatomy, especially their neck. And don't just lay a super young kid flat because they'll, you know, they do that and then they start snoring and stuff. And just like I say this a lot, people that need IVs get IOs. People that don't need an IV almost always get a freaking IV, all right? But people who need IVs get IOs. All right, and this is what the kid sees, so keep that in mind, okay? And then they were talking about the sniffing thing and how you make sure that they don't put their chin on their chest when you're laying them on the ground. And the IOs. How many IOs have we gotten? Like everybody's gotten. So just remember, you don't pull the trigger out here and do that, right? You punch through the skin, hit the bone, and then just spin it in. Just only take a couple rotations and it's through. Okay. IOs are awesome. In adults, you should always use the right humerus. I still can't get people to do that, but right humerus is the one you want to use. much faster rate of infusion. I don't know what John was trying to get at with that. Oh yeah, the triangle again. All right. Signs of abuse. A couple of different things. If they're not old enough to walk, they usually don't have broken bones. Okay? Or a happy kid doesn't have broken bones. You know, you can have inborn errors in metabolism like osteogenesis imperfecta, etc. But if their level of development should match the injury that they have. You know, so if you've got a 12-weeker and then they said they roll off the couch, no. 12-weekers don't have the ability to, you know, roll yet. Maybe they do a little bit, but it has to match. A kid that won't respond to you is wary, is usually poor eye contact, wary, kind of flinches every time that you try to touch them, is another sign of abuse. The injury does not match the history. Where did that one come from? Anybody know? The red butt?
Hot water.
Yeah, hot water. They forced him into hot water. Not only hands, but electrical cords. They hit him with electrical cords, and you'll see that pattern on kids. That's a big board question. And then this is also abuse. This is just neglect. So consistency of the injury with child's developmental age, child abuse, history inconsistent with injury, inappropriate parental concerns, which is like every Amish person. You know, he fell out of the top of the barn. He fell off the top of the barn. And we decided maybe he needed to be checked out. He's unconscious and seizing. Delay in seeking care, bruises of various ages, unusual injury patterns. You get the idea. If your spider sense starts going off that this does not match, it probably doesn't match. You're probably being lied to, especially if their mouth is moving. Right? All right. Heart disease. There's 5 congenital heart disease, truncus arteriosus, transposition of the great vessels, tricuspid atresia, tetralogy of Fallot, and total anomalous hookup. Okay, those are the 5 congenital heart diseases. They all have various presentations, but in general, they will just look like a sick cyanotic kid. You'll see a sick cyanotic kid that you just can't make much better. And sometimes they'll have a murmur. Most of the time they'll have a murmur. All right. What's a ductal lesion? What's a ductal dependent lesion? Anybody know what the ductus is? The ductus arteriosus? Should have a picture of it. In the fetal circulation, you have blood coming in from the superior vena cava and the inferior vena cava, and from the umbilical cord coming in from here. Now, you don't want this. This is oxygenated blood in utero, right? This is blood coming from the placenta. You don't want that blood going to the lungs, because the lungs are doing fine anyway, right? You want some going to the lungs, but you want that oxygen, you know, energy-rich blood going to the brain and the heart and everything else that you need it to go to. There's 2 ways to do that. One, boy, I hope these aren't permanent. One is there's a flap right here. It's hinged here. Okay? And this is the foraminal valley. Okay? And what happens is, in this situation, the pulmonary artery coming out of the right ventricle, the pressure in the pulmonary artery is high. It's higher than the pressure in the left atria for sure. And as a result, blood preferentially goes through the foraminal valley. Pretty slick. In the aorta, so here's the aorta coming out of here. I won't draw it over the top, but the aorta is doing this. And the pulmonary artery is coming out of here. And here's the pulmonary artery going to the lungs. Tracking? So this is the pulmonary. The other thing that happens is that you have something called the ductus arteriosus, which is right here. And since the pressure in the pulmonary artery is kind of a little bit higher than it is in the aorta, blood coming out of the right atria shoots right into the aorta, and now you've got blood that's actually bypassing the lungs. Now, not all of it, but some of it. Now, when you come out of the womb and you take your first breath, the pressure in your lungs, the blood pressure in your pulmonary artery, drops from what was 60 millimeters of mercury down to about 15 to 20 millimeters of mercury. Whereas the left side of your heart, you now have peripheral vascular resistance, so the left side peripheral vascular goes up. So the pressure here is now higher than the pressure here, and this thing does what? Slams shut. This ductus arteriosus, that thing takes a while to close. That takes a while to close. It actually takes about 2 to 3 days to close. And you can make it stay open. You can make it stay open by giving them prostaglandin E, or E1. You can make it close by giving them a non-steroidal anti-inflammatory like Motrin. That's why you don't want to give kids Motrin, especially in that first age, or especially pregnant women in their third trimester, because it'll make that ductus arteriosus kind of squinch up. Let's say that you're born and you don't have a left ventricle. Let's say you don't have a left ventricle. You've got a single ventricle. Okay? If you've got a single ventricle and you're dependent on your right ventricle to stay alive, you have a ductal dependent lesion. Does that make sense? Because they don't have an aorta. They don't have an aorta. They're dependent on, this. If they don't have a left ventricle, this connection here doesn't exist. They're dependent on this component. That's an example of a ductal dependent lesion. Ductal dependent lesions present within the first 2 weeks because the ductus starts to squeeze off and the kid starts to look sick. That's what a ductal dependent lesion is. As opposed to, if they're older, then they're a non-ductal dependent lesion, which would be like tetralogy of Fallot or some other ventricular septal defect, etc. All right, but that's what they're talking about when they talk about a ductal dependent lesion. Hypoxia in heart disease. Weren't you with me with the Amish kid that we cardioverted with the Amish kid? That kid had a common atria. A common atria, 2 outflow tracts from the right ventricle, and I think they had a VSD. But with a common atria, what do you think that their saturation is going to be on a normal day? 95? Yeah, that kid's sat was normally about 80. Yeah, right. So that's a clue to the fact that you're dealing with somebody with a congenital heart disease, is you give them oxygen and their sats don't come up, right? And then you have a big murmur. So in heart disease, what is the kid's normal saturation if they know it? Most kids in Western developed countries, they know exactly. Most moms know exactly what the sat is. That's another thing. If you have a sick kid, a kid with a long-standing chronic health issue, the mom knows exactly what's going on, especially in the U.S., especially because the mom is the one. Dad's going to work. Mom stays in the hospital with a kid. Mom knows everything about that kid, and mom is the patient. Mom is the one you have to make feel better. And she usually knows more than you. If no improvement with oxygen, then you have a shunt until proven otherwise. Do they have congestive heart failure? The most important finding with congestive heart failure in kids will be hepatomegaly. They'll have big livers because of the back pressure, okay? Or they'll have abdominal pain. You'll push on the right upper quadrant and they'll have pain. Consider sepsis. It looks very similar to congestive heart failure. And they have a higher risk of sepsis because their cardiac output is compromised already. They're already usually operating at what they can handle. DKA, endocrine. We're now into the E for the Misfits, right? Endocrine, DKA is it. For kids in this age, especially The presenting complaint is going to be they've been sick for 3 days. Okay, they've been vomiting for 3 days, and now they're not acting right. That's going to be your key, and they're going to end up with the sugars in new onset DKA aren't typically all that high. It's going to be like 500-600. Okay, it's not going to be like the old big fat American that has a sugar of 1200. Okay, it's going to be a kid that's 300, heart rate of 180 to 190, vomiting, not acting right. And what's the other big thing that's going to give away the fact that you have an acidosis? We talked about this, right?
Would be the breath.
Yeah. Well, it's not the acetone. You're talking about the. You know, there's a lot of people that can't smell acetone. I can't smell it. I can't smell the acetone that people describe. Yeah, yeah, yeah. But they'll be tachypnic. They'll just be breathing so fast to try to breathe off that acid. Yes, absolutely, Kussmaul's, yeah. Don't give them a bunch of sodium bicarb or fluid, okay? In pediatric DKA, the idea is, yes, they're usually a little fluid depleted and you can hammer them initially. But these kids usually require treatment over a day or two to get them kind of leveled out. If you hammer them with fluid and give them a bunch of sodium bicarb, you can make their brain swell, and then the first thing that you'll realize is that they're having a seizure. And that's the first sign that you have screwed it up, is that they're having a seizure. So don't do that, okay? No insulin boluses. Another thing, you know, what's the treatment for hyperkalemia? Does anybody know what the treatment for calcium? What else? Sodium bicarb. What else? Albuterol. Excellent. There's a fourth. What is it? No. Insulin and glucose. Insulin and glucose. So insulin is the key that glucose uses to get into the cell. If glucose doesn't have a key, it can't get in. But when glucose uses insulin to get into the cell, it takes its buddy potassium with it. So one of the treatments for hyperkalemia is you give them insulin and glucose, and it pulls potassium in. But let's say that you're dealing with a kid who is a DKA and has a total body potassium that's low. Now you give them a bunch of insulin to get their DKA under control, and all of a sudden you have a functional potassium concentration of like 1.8. And then they go into VTAC, and you look bad. So don't do that, okay? Beware of so no insulin boluses. Start your fluids appropriately, 10 milliliters per kilogram. Beware of hyperkalemia, beware of cerebral edema, and disconnect. You know, if they have if they have an insulin pump, just take it out because you want to own that business anyway. And look for a sign of infection. Typically, these kids have some infection that's put them over the edge. Urinary tract infection, pneumonia. No big, don't give them 20 units of insulin. No, does anybody know what an insulin drip is? What's the dose on an insulin drip? Any ideas? A good start is 0.01 units per kilogram per hour. Okay, so if you got a 10 kilogram kid, what's your rate of insulin administration? 10 kilogram, 0.01 units per kilogram per hour. Huh? Yeah, it's 0.1 per hour. All right, look for sepsis. Hypoglycemia. This is going to be the kid that's septic. If we're talking about pediatrics and we're talking about hypoglycemia, this kid is septic. Okay, or they're a DKA kid that their parents are trying to kill them, I guess. History of diabetes, not eating, and probably dehydrated. But like I said, the hypoglycemic kid either has an insulin-producing tumor or they're septic. And they're typically present as seizure or mental status exam. That's going to be the thing. Pale, clammy, sweaty, dizzy, confused, seizure, coma. Remember when you're trying to figure out what to do, when you're sitting there and you've got this patient and you're like, you know, it's gonna be 10 o'clock at night and you're gonna be in a place with no electricity and somebody's gonna bring you a kid or an old person. Remember, you've got to get those 8 vital signs. And what are they? Temperature, pulse, respiration, blood pressure, sat, End tidal CO2 if you're using positive pressure ventilation. Glucose EKG. 1, 2, 3, 4, 5, 6, 7, 8. You should have 8. This is where you start. If you don't know what to do, you know, because you don't get a bunch of gunshot wounds. You don't get a bunch of falls and car accidents and stuff like that. You're going to get sick kids. That's what people are going to bring you. You're going to get sick people. And when you're trying to figure out what the hell do I do, start with that. And you will be able to figure it out after you get that done. All right. So when you get a kid and their decreased level of consciousness or coma or seizure or whatever, you're going to pick up on all this stuff if you can just get that stuff. All right. For older kids, like older than 2, hypoglycemia is less than 45. What's the hypoglycemia for an adult? Yeah, like 70. It's lower for kids. Nobody really knows what hypoglycemia is for a baby. We don't know. We know a lot of kids do just fine at 35, 40. Okay? So if they're less than 45 and a little kid, if they're less than 45 and symptomatic, then treat it. But 20 is clearly too low. Okay, we're pretty sure, but we don't know where it lives between 20 and 45. All right. Sugar. This is going to be on the test. This is going to be on the test. Okay, what's the dose of what is the appropriate solution in volume for a kid this age with a sugar of X? They're going to ask you that, or something, a variation on the theme. And I'm telling you that that's not the way the world works today. The way the world works today is everybody gets D10. In a kid, you're using 2 cc's of D10. 2 cc, I know this is D25, but we don't use D25, we use D10. It's 2 cc's of D10 per kilogram, and you just run that in and they'll perk up. For adults, you just hook up some D10 or D5 and let it run until they wake up. That's where we're at today. We used to do this whole, thing of D50, and we had a lot of people that would come into the ER with the sugars of, 400 or 500, and now we've got other problems we got to deal with. Okay? This is much more appropriate. We're seeing this over and over again. Okay? So if you have to, the best way to do it is to carry a liter of normal saline and an amp of D50. Because now you've got normal saline that you can use, but you can make D10. And I'll let you figure out how to make that. I'm not going to go into how to make D10 with that. But that, especially if space and weight, if you're trying to work with a ruck kit or a truck kit, being able to make D10 is pretty useful. I will say that if you take a 10 cc syringe and suck out a cc of D50, help me out, Russ, because I haven't figured it out lately. If you take a cc of D50 into a 10 cc syringe, or is it 2 cc's?
2 cc's.
2 cc's of D50 into a 10 and then suck up the rest, you end up with D20. D10. I just have to think about it all the time. Okay?
Which is the problem.
Yes, exactly.
Because when you have a really sick kid, it's not a good time to do math.
So 2 cc's of D50 in a total of 10 cc's of normal saline gives you D10. Okay, and you can extrapolate from there. As opposed to carrying 1 bag of D10. Now you can't use that on the trauma guy or on the other kid. Yeah. All right, inborn errors of metabolism. You're not going to see that in the U.S. because we typically screen for all that at birth, like phenylketonuria, maple syrup urine disease. I mean, all these other stuff, we screen for that. So you typically don't see it. You can see it in like isolated, like reservation populations, isolated populations in the U.S. Outside of the U.S., game on, right? You're going to see everything. And they're just going to be FLKs, right? Funky looking kids. that just look sick all the time. You just
They won't see that on the national registry.
yeah, you won't see any of this stuff. I hope, but they won't see PKU, phenylketonuria.
I'd be surprised.
Okay. Galactosemia is another one, disruption of converting galactose to glucose. These kids end up being hypoglycemic. Poor weight gain, loss of milestones, recurring vomiting and diarrhea. That's a big one. Deafness, blindness, various cancers all come from both of these, but we don't see this here because we screen for it when they're young. And yeah. All right, intestinal disasters. Remember, we're working through misfits here. Any kid that has persistent vomiting, like you can't control it, you have to worry about it, especially the younger they are. Pyloric stenosis is the one that everybody wants to know about, you know. My kid has projectile vomiting. Yeah, every kid has projectile vomiting, okay? It's just normal. All kids throw up. The difference is some kids, they just won't stop throwing up, and then they start to look funky on their triangle, right? So this is typically going to be a firstborn male in their first 2 years. So 18 months is usually where you hit this. Firstborn male in their first 2 years is where you get pyloric stenosis. And they come in and they look sick because they've been puking their guts out. It's not, hey, my kid's been throwing up for a couple of days. It's like, this kid looks sick and he just won't stop throwing up. Malrotation is usually newborns, okay? Pyloric stenosis is older. Malrotation is newborn, usually for sure within the first 2 weeks to 2 to 6 weeks, they're going to start showing up with malrotation. Another one would be, there's another, this is pyloric stenosis. Intussusception, again, this kid presents with this, I thought that was a pylorus. It's intussusception, where it's like a telescope, you know, like an old-time telescope where one segment of bowel gets sucked up. Usually there's a polyp in the lumen of a piece of intestine, and that polyp gets pulled into the subsequent section, and then you end up with a transient bowel obstruction, and you'll end up with a kid that has his knees pulled up, and if you test their poop, if they have an intussusception, they'll have a heme positive poop, which is great. Okay, if their poop is heme negative, chances are they do not have one of the big intestinal problems like intussusception, Meckel's diverticulum, etc. Pyloric stenosis is just, you know, this kid. What John's getting at here is bilious vomiting. If you have a kid that's less than 6 weeks old and they are puking up green stuff, that's a problem. Bilious vomiting less than 6 weeks is a pediatric surgical emergency until proven otherwise. And there's no way to figure that out. Okay? If that kid is less than 6 weeks old and it's truly bilious, it's green. And when I say green, I'm not talking like, oh, it's a mild kind of mint. It looks like emerald juice. Okay? This is a real problem. I've only seen one in 20 years that actually had real bilious vomiting. That is Meckel's. Meckel's is actually gastric mucosa. So the acid-producing mucosa, typically in your stomach, just finds itself implanted somewhere else in your gut. And now you have acid-producing mucosa somewhere else in your gut, and it bleeds and will cause intolerable pain. And the way you treat it is you put them on Prilosec and you take them to surgery later. And then dysentery, which is what you guys are going to see. The thing about dysentery in all of its various forms is it's just a problem of, typically, it's a problem of hydration. If you can keep them hydrated, they usually live through it. Okay, but you got to keep them. That's a problem, especially with cholera. You know, they'll poop so much that you just can't keep up with it. All right, hematochezia. Hematochezia is pooping blood. First thing you do is, you know, what's going to happen is they're going to bring you this kid and they're going to say, my baby's pooping blood. First thing you do, find out if it's blood or if it's red velvet cake or if it's whatever, Okay, the first thing you do is try to find out if it's actually blood. You just take their diaper and you take a little Hemocult card, do that, test it, not blood, bye. No kidding. It's gonna be okay. You gotta make them feel better. You gotta convince them that you're not a complete idiot, okay? All right, the other causes of actual rectal blood are that it's usually coming from outside of them. You know, it's coming from their nose, it's coming from their mom. Kids will typically have a little bit of bleeding initially, but this is the big one, especially when you're outside of that 12 weeks. After 12 weeks, the kid's actually starting to make poop, right? Well, they make a big poop, then they take a big poop, and then they rip stuff, and then they bleed. That's typically what happens. Now, this is painless rectal bleeding. If it's abdominal pain with heme-positive stools, you're dealing with something else. Meckles, intussusception, some other problem. Pain with heme-positive, problem. Painless, heme-positive bloody, not so much a problem. And that's typically what you get. You go like, my baby is pooping blood. Okay. See ya. All right, and toxins. Holy crap. I mean, kids just eat everything, okay? What's the problem with oil of wintergreen? Does anybody know what oil of wintergreen is? Super saturated aspirin, okay? And it smells good and it tastes good and you can put it in stuff and people eat it all the time. Other things, I mean, the list is too long to even. But typically, if it doesn't taste good, they don't take it. Tylenol, bottles of Tylenol, bottles of, you know, we had a problem with vitamins for a while. The problem with vitamins was the iron, not the vitamin. You're gonna have to know your antidotes for the test. Know your antidotes for the test. Every board, every test you'll ever take, they're gonna ask you they're gonna say, they took this, what should I give them? That's a gimme, okay? So know the antidotes for the test. Carbon monoxide, oxygen, organophosphates. Do we even have that? Yeah, we do, but it's in pesticides, and it's typically not as much as you think. Give me an example of a tricyclic antidepressant. Anybody give me one? No, that's a selective serotonin reuptake inhibitor.
Amitriptyline.
Amitriptyline, also known as Elavil. Elavil is about the only one left. Used for sleep, used for chronic pain. Despite the fact that we identified that TCAs were a big problem, Elavil still persists in the environment. Remember, if you're dealing with a blocker overdose, so if you're dealing with a sodium channel blocker, you give them what's being blocked. So if it's a sodium channel blocker, you give them, in what form? What do you give them? Sodium bicarb. Sodium bicarb, bigger load of sodium. If they took a calcium channel blocker, what do you give them? If they took a beta blocker overdose, what do you give them? Betas. Yeah, good. That's glucagon. Yeah, don't give them betas. Beware, acetaminophen and acetylcysteine. It smells and tastes like rotten eggs. It was only available in oral form, which I thought was just great because these people would come in and they'd have taken a big handful of Tylenol and they were going to. You will die. You will flat out. If you take enough Tylenol, you will flat out die. It is a horrible, disgusting death that takes about 36 hours, but you will 100% die. There's nothing anybody can do about it. As long as if you get the antidote in them in the first 6 to 8 hours, they won't have any effects. But if you just take, like I had a guy that took a bunch of Tylenol PM, which is Tylenol with Benadryl. So he took an overdose of Tylenol and Benadryl, passed out for 24 hours, came into the ER because he was really sick. And I was like, yeah, you're gonna die. And he did. And I had to sit there with his wife and his kids, and I was like, there is nothing we are going to do. He's going to die now. And then he died. The problem with benzo overdoses, Valium, Ativan, Versed, etc., there is a reversal for this. It's called flumazenil, or Ramazicon. The problem with Ramazicon is, what happens if you withdraw precipitously from a benzodiazepine? What is the consequence of withdrawing from a benzodiazepine? Let me know. You seize. you have a seizure if you withdraw too fast. Okay? What do you give people with seizures? Yeah. So if you take a Valium overdose and I reverse it with flumazenil and you have a seizure, I'm screwed. So don't do that. Yes, they're going to talk about, they might talk about that on the test, but the answer in real life is don't do that. You know, the problem with benzodiazepine is that they don't breathe. So breathe them, right? Right, so know your toxins, know your antidotes. They talk about the bad, how much it takes to hurt you. I've never seen there's a couple of questions about that in some tests. Like they're gonna ask you what the toxic dose of Tylenol is, but I don't think they're gonna ask you that.
They may ask them about dystonic reactions.
Okay, so a person comes in and their neck is flexed like this and their face is all scrunched up. Okay, what's the most likely drug that caused that? And it's always from here up. Their face or their neck is distorted and locked. Okay, if that's a dystonic reaction, usually caused by a dopamine blocking antiemetic like Phenergan, Reglan, Compazine. Okay, so they went home from surgery, they took their Phenergan, and all of a sudden they come in and they're all locked up and everybody thinks they're having a seizure, right? And it's usually about a 10 to 14-year-old person. Anybody know what the antidote to a dystonic reaction is? There are two. Benztropine or Benadryl. Okay, just give them 25 of Benadryl and they just, oh, I feel so much better. And you look like a hero. That's awesome. I don't think they're going to ask you about, what's the trade name for benztropine? Cogentin. Okay? Remember the 3 components of what a sick kid looks like? Remember the 8 things that will start making you think about how to get out of trouble. All right.